Hello, everybody. Welcome, welcome. We're going to start this with just a little bit of housekeeping. Thank you all so much for being here today. Some things that to let y'all know, the chat box is available for y'all to communicate with each other. You can also utilize the emoticons or reactions at the bottom that are available to you, the clapping hands, hearts, whatever you want to express. Just a reminder also that all microphones are off, so you are unable to unmute yourselves, but you are invited to turn on your cameras and let us see you. This PowerPoint will be available afterwards, and there will also be a survey being handed out at the end that we really encourage you to fill out to let us know how we're doing. All right, if you can go to the next slide, please. Okay, so this is just a disclaimer that this training is offered through the Crisis and Recovery Enhancement Center, which is funded by the California Department of Health and Care Services and administered by the Center of Applied Research Solutions. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the California Department of Health Care Services. In the case of any security issues that may occur, this session will immediately end and will not resume. A separate email will be sent to all participants with further instructions. Thank you. And then the next slide, please.
Next one after this one too.
Okay. You are also welcome to use the chat box. Please use I statements in the chat box and avoid making any comments that are destigmatizing or otherwise injurious towards others. Your message will be received by the chat box monitor, me, who will filter all comments as able. The chat box monitor will also will not share any comments to the audience that are harmful. We'll use polling features to invite group participation. If you experience any tech challenges, our CEvent tech host is available to support. Please place any message with technical issues in the chat box and they'll be addressed. Please follow the community agreement and reach out for support if needed by contacting a support line. If you need to step away from this session and would like to go to a quiet place within the conference for self-guided grounding, please exit from this session and go to the exhibitor booth entitled Calm Space. So we've come to the end of our disclaimers, and now I'm handing it off to Stephen. Thank you all so much for listening.
Fantastic, Sophia. Thank you. And it is just a pleasure to be here with everybody today. I'm adjusting my presenter screen a little bit so I can advance the slides. But look, I'm looking forward to getting us underway. I'm going to give you a bigger introduction later on as we get to this presentation. But for now, just know my name is Stephen Samra. There are several folks in here that I've seen from yesterday, and just welcome back. Glad to have you guys. But what I want to do right now is just take a quick look at our objectives. And David, yes, there will be a copy of those slides. I think that they can be put in the download pod, I believe, or the chat box pod, but I'm not positive. But we'll absolutely make sure that you get a copy of them. I also, before I go further, I also have a number of handouts that would go through. Normally, I would hand out during this particular session. But the way that you have to get at it, it's a little bit tricky. So what I'll do instead is, if you would like a sort of basket of handouts that I have, because I have some really good ones that I think would provide really great resources long after I'm done with this training. All I need to do is have your email address in my chat box. And I will mine that chat box when we're done, just like I did yesterday. And I will get them off to everybody who asked for them. And if you do that, I will also throw in a couple of additional ones that I didn't really have planned for today's session. So I'll try to make it as valuable as possible for you. And David, I saw that. Thank you for the email address. And again, we'll collect those as folks want to add them, and we'll get cooking in the meantime. So in terms of our learning objectives today, basically, I think what we're trying to do is I'm hoping that at the end, you'll be able to list at least 2 strategies to reduce stigma in your workplace. You'll be able to identify and describe the different types, there's 3 types of stigma. And then you should be able to talk pretty authoritatively about the importance of person-first language and why that matters in the context of trying to reduce stigma and remove it. As I said, I had a bunch of handouts. I will make them available to everybody, and we can get to it. So without further ado. All right, so look, folks, it's really no secret that we're pretty much swimming in stigma every place that we go. And the question is, what is stigma? Well, Sampson's definition for stigma, it's the one that's used, pretty frequently. It's a mark of disgrace or infamy, a stain or a reproach, as like it would be on somebody's reputation. And what it does is it really refers to attitudes and beliefs that lead people to reject, avoid, or fear those that they think might be different. And stigma remains the biggest barrier to treatment that is faced by patients or clients. And the terminology, we're going to talk more about that. And the terminology, the words that we use to describe addiction and mental illness has contributed immensely to stigma. And just the fear of the judgment that comes from stigma means that people with mental and substance use disorders are far less likely to seek help, and they're much more likely to drop out of treatment programs early as well. And you're going to hear me say that a lot through this presentation. Mental and substance use disorders carry a high burden of stigma. And if you want to get folks into treatment, you might not want to stigmatize the person, the treatment, or the effort to get them there either. There have been lots of derogatory and stigmatizing terms that have been used to describe those of us who have mental health challenges or substance use challenges. And if it's substance use, we even have some new sort of derogatory and stigmatizing words and terms, and those were used throughout the war on drugs. And it was really the effort to to dissuade people from using, just say no, and that kind of stuff. Education really took a back seat back then, and it was because we hardly knew anything about addiction. We just really didn't know. And even though, this is the crux of this, even though we know much more about the science of addiction than we did back then, and even though we know much more about the brain's role and the diseases of both mental illnesses and addiction, strangely enough, that increase in knowledge did not result in decreasing stigma. And we're going to come back to why that is, because there's a reason. For now, I just want you to understand that changing our language, it's one of those things that we can use to reduce stigma that will all by itself benefit all of us. It allows those of us who have been stigmatized to more easily regain our self-esteem. It allows lawmakers to appropriate the appropriate funding. It allows doctors to treat us without the disapproval of their own peers. And believe it or not, that happens a lot at that level. It allows insurers to cover treatment, and it really helps the public understand that these are medical conditions as real as any other things. Now, many of us are already focusing on stigma reduction through person-first language. We're going to talk more about that as well. There are a couple of good resources that I'm going to send to you as handouts. And if you just Google, person-first language or strengths-based language, you will get all kinds of those examples. And I'll just add here before we go further, I'll move back and forth between addiction and mental illness because both of them have tremendous stigma. And they both have, interesting and potent challenges that are associated with them. I tend to use substance use issues to drive home the power of stigma because right now it's what's prominent in the news and on people's minds today. But I pretty much make a blanket assumption, and I do this from my own lived experience, that almost all substance use is driven by some sort of an underlying mental health challenge. Whatever that might be. And since we know that addiction itself is classified as a psychiatric disorder, we're in many ways comparing apples to fruit salad. There's a lot of differences here, but there's a lot of similarities as well. So there are three types of stigma: public, institutional, and self-stigma. Now you can go online and you may find, I know Pat Corrigan does a ton of work, a great respect for Mr. Corrigan, and he talks about the 4 types of stigma, and one of the other types is avoidance. But I don't really see it that way, because avoidance is part of all 3 of these stigmas. So I'm just sharing that if you went and Googled this and looked around, you'll find several iterations and different varieties of this, but ultimately, this is what it boils down to. So with micro or self-stigma, sometimes we refer to this as internalized stigma. These are the judgments and negative opinions and evaluations that we hold about ourselves. They are psychological in that they affect how we feel and they impact our behavior. And they are also existential in that they influence whether we think we or even life itself has any meaning or purpose. Now, in some cases, the way people look at us can trigger these internalized scripts of judgment. And beyond storing these experiences, we actually begin to believe them. We keep them active, developing these structures of shame and guilt, and those structures can cause us to spiral into isolation, loss of will, feelings of hopelessness, return to use, etc. Acknowledgement and acceptance of our inherent dignity and the fact that our right to a life of respect, possibility, and fulfillment is not a privilege or dependent on others, but instead something inherent, already in place. It's a powerful way to counterbalance and diminish the harm that comes as this sort of internal stuff erodes the self. And this type of stigma keeps people from seeking services for their mental health or substance use challenges. It causes a loss of hope, a loss of self-esteem and confidence, and I think this is the worst part. It creates this vicious cycle, and I'm speaking for myself here, but I know that this is not just my experience. It creates this very vicious circle of coping with substance misuse to combat the pain of the stigma around it, and that leads to ever more self-stigma, and then we misuse more substances because we are so hurt by the stigma. And it can also exacerbate any mental health problems we might have as we try to blot out that pain and the shame of all that internalized stigma messaging. Self-stigma and internal stigma is why many of us with addiction and histories and histories of mental illness find it really hard to look at ourselves in the mirror. Now, meso or public stigma is how we think about others, and not just individuals, but also groups. Public stigma involves 3 different processes: labeling differences, connecting those differences to stereotypes, and then separation, sorting us from them. And this ensures that the stigmatized individual or the group experiences a loss in their social status. Basically, we've kicked them to the curb because it's us versus them now. Public stigma occurs in our closest circles of relationships. These are the family, community ties, and our relationships, even with our recovery peers, and in some cases, those who provide treatment and care. These stigmas are often rooted in fear, in distrust, in betrayal, and in disappointment. And they lead to a fracturing of relationships, of your family, and of the groups that you've engaged in. When our treatment and care relationships are corrupted by stigma, access to and the quality of the care actually goes down. Rebuilding and strengthening relationships or establishing a new social network, well, that's a good, strong antidote to the impact of public stigma, but it's challenging to do it. Public stigmas can be difficult to maintain when family and community members, providers, and people struggling with mental illness and or substance use disorders are able to witness firsthand the reality of recovery. Memes and signs that are suggestive of moral failure. You see comments in print and online media using images of like people overdosing in their cars. These are examples of public stigma. Now, macro or structural stigma are the laws and the policies and the protocols and the practices that produce and maintain stigma at local, regional, and national levels, and within institutions and organizations like healthcare and criminal justice settings. These stigmas are often collectively held. That is, these are social norms. So together, most of society agrees that some people, the homeless, addicts, junkies, illegals, etc., are problems, and they need to be distanced from everybody else. And then these attitudes get codified in laws and regulations and institutional protocols and practices that help reproduce and manage them. And these structures have to be broken and dismantled if you're going to have stigma go away. And this takes new laws, new policies, the defunding of some social institutions, the redistribution of some of the resources. You can see here already how much of a challenge really impacting structural stigma is going to be. But it also requires a meaningful commitment to equity and equality of opportunity and of access to healthcare and just basic supports. Structural stigma is discrimination present in the healthcare system, and it's manifested in the implementation of policies. It utilizes language that leads to a lower quality of care, limited and fragmented access to behavioral health treatment, overuse of coercive approaches to care, and usually the bias itself, it targets very specific and easily stereotyped stuff: race, gender, nationality, sexual orientation, and age. And we know that direct discrimination is technically illegal in the United States, but many believe that indirect discrimination still very pervasive in many social institutions and daily social practices. And one of the best examples I can give you, the recent transgender ban in the military. It's a great example of structural stigma. So individuals understand and they perceive and define stigma and its impact in a bunch of different ways. And when it's applied toward an individual experiencing something like a substance use disorder or a mental illness, the target and the impact of that stigma often includes family members. And this is called courtesy stigma. And it means that sometimes family members and people who are associated with persons with mental illness or a substance use disorder experience the same kind of avoidance that the stigmatized person does because of that stigma. And courtesy stigma plays a sort of a more insidious role in mental health and addiction services because organizations might receive less funding because of the type of service they provide. And we all know this, there's often less support money. As individuals struggle with addiction and mental illness, ashamed to ask for support because of the stigma, communities then lose that positive, sort of impact and resource that those individuals could provide it. And stigma perpetuates this often irrational and unfounded fear about an individual who has a mental illness or an addiction challenge. I was at a CADCA conference a couple of years ago, and I was in a breakout session with a bunch of physicians, addiction physicians, and I will never forget them telling us that they received so much stigma from their peers, from other doctors, that many of them regretted becoming addiction physicians. And if you can't, I still can't really wrap my head around that because you would expect a physician to have the level of knowledge and understanding and compassion that would help eradicate stigma, not contribute to it. Now, in 1996, there was this general social survey, and they do them, I think, every 10 years or so. And this one compared stigma responses with surveys that were done in the 1950s in the US on attitudes about mental illness stigma. They were specific around mental illness at that time. That comparison really indicated that public knowledge about mental and substance use disorders had increased, specifically as it related to the neurobiological underpinnings of these disorders. That it was, people were understanding, wow, this is actually a disease. It's a disease. It's not a moral failing. And there was greater public awareness of the stigma associated with these disorders, but public stigma itself remained high. Results from the 2006 study found even greater sophistication in the public's knowledge of disorders and treatment than they found in 1996. But guess what? Stigma levels did not decrease over time. Across countries surveyed in the stigma issue around, it was a global context study, levels of recognition, acceptance of that neurobiological cause of mental illness and substance use, and treatment endorsement, all of them really high. People agree this is a disease, and stigma is, we understand this is contributing, but the stigma itself did not decrease. And the researchers were stunned. But what they learned was there's a core of 5 prejudice items that persist. And researchers call this the backbone of stigma. So you see the 5 on your screen right now, but they don't make a lot of sense when you look at them like this. So let me try to give you some context. So for lack of trust in an intimate setting, here's how you think about that. Do you want your cousin John, who has a really severe crack addiction, do you want cousin John in the same room with grandma's pocketbook on, the 3rd of the month when grandma gets her Social Security? What about possible contact with the vulnerable group? Do you want cousin John in the same room as grandma, or with a vulnerable child, or your 14-year-old daughter or granddaughter, and the potential for self-harm? Who do I call when my new renter John lights his hair on fire at 3 o'clock in the morning? I had a landlord ask me that. The MISUD being opposed to power or authority. So if we tell John he needs to leave, is he going to listen? Or will he turn violent? Or does he go quiet? Or does he just ignore you? And the final one is, how do you interact? Unsure how to interact with a person who has a mental illness or substance use disorder. What do I even say? And worse, what do I do if things get weird? So this backbone of stigma, it is pernicious. It hangs there, and it's really, really challenging to get away from. And I see David in the chat talking about, I observe this a lot in the emergency departments and in client homes. And David, yes, it would be, doesn't surprise me at all to hear that. Now, people with addiction face a lot of different stigmas. They can face stigma from within, they might blame themselves. They can face stigma within the recovery community. And this is really true for people who use medication for their illness. So while we wouldn't shame somebody with diabetes for being on insulin, people with an addiction who are on a life-saving medication are often shamed. They can face stigma from the people who are supposed to be treating them too. And there's a long-held belief in pockets of the medical system and among some clinicians. Remember I told you about the doctors who look down on the addiction physicians? Some of these clinicians think that treatment is ineffective, or frankly, that people just don't get better. And finally, people with addictions face huge stigma from the general public because the general public sees it as a moral failing, and they erroneously believe that addiction is a choice and it's not a disease. So how does stigma then impact an individual? Well, this slide just lays it out. Prejudice and discrimination exclude people who have mental health or substance use challenges from activities that are open to others. And that limits a person's ability to get and keep employment, get and keep housing, get any health care, be accepted by family and friends, make new friends, or even engage in the social activities that are of interest to them. And then that prejudice and discrimination, it gets internalized. We start believing it. And we believe that negative stuff, and then our self-esteem crashes. We have plenty of guilt and shame. We use again because we can't handle all of that pressure. And now we've added to the guilt and shame game. And that prejudice and discrimination, it can cause people to keep it a secret, because if you don't know my history, you can't stigmatize me, you can't shame me. So as a result, they don't get the help they need, and their mental health and their substance use issues are far less likely to come to an end. Stigma not only inhibits help seeking, I think we know now that it also weakens the impact of that help when it is eventually accessed. Let me provide a couple of examples of stigma. People with substance use disorder and those on medication-assisted treatment might not even be accepted to a post-acute care facility. Basically, what that says is, if somebody's using medication-assisted treatment, do we even believe that they're in recovery? Or are we supportive of that pathway as well as all the others, 12-step, faith-based, whatever gets you into recovery? And here's another stigma example, and frankly, this one's personal. I'm a person in long-term recovery, but I have addiction, criminal justice involvement, and mental illness in my background. Now, if I were to contract the COVID virus, and now I'm fully vaccinated, so it's not that big of a worry to me, but if I were to contract the virus, where do you think I would have ranked on the list of folks who would get placed on a ventilator in the event I ended up in the emergency room? Yeah, my sense is they probably wouldn't even bother to put me on the list. And I think we all know why that is. It's because substance use disorder is among the most stigmatized conditions in the United States and around the world. People don't want to work with, be related to, or even see people with a substance use disorder in public. When you add in mental illness, it just exacerbates all of these things. And many people, they believe that people with SUD can or should be denied housing, employment, social services, even healthcare. And some healthcare providers treat their patients who have substance use disorders differently. There are some clinicians out there who have lower expectations for health outcomes for those of us with substance use disorders. This in turn can affect whether the provider even believes the patient is deserving of treatment. And some providers, they falsely believe that substance use disorders are within our control. They cite feelings of frustration and resentment when they treat patients with substance use disorders. Think then how frustrated and resentful those of us with SUDs are about our own addictions. And this unconscious and often unintentional bias, I don't think the clinicians are trying, intentionally to say we're failures, but it's real. And many researchers suggest that unconscious bias occurs automatically as this brain of ours makes these really quick judgments based on our past experiences and our backgrounds. And as a result, certain people benefit and other people are penalized. And I can give you 2 quick examples. Resumes are a really consistent source of unconscious bias. There's been a recent study that gave a group of managers a set of resumes. Some of them were exact duplicates, but only the names had been changed, and resumes with Anglo-sounding names received substantially more callbacks than those with diverse names of other origins. And here's another one. You need some help programming your smartphone? Well, you don't go to a boomer, you go to a Gen Xer, or you go to the younger folk. Well, listen, that's a pretty accurate assumption, but it's not always the case. And I can do a pretty good job with my smartphone. I'm not nearly as good as my daughter, but I can navigate around and figure it out. The impact of stigma, it's pernicious. It erodes confidence that substance use disorder is a valid and treatable health condition. It's a barrier to jobs, housing, and relationship. It deters the public from wanting to pay for treatment. It allows your insurers to just say, we're restricting your coverage. It stops us from seeking help. It impacts clinical care and treatment decisions. And regardless of where it comes from, the impact of stigma is real, it's pervasive, it's punitive, and it is insidious. It is hidden, it is all around us. So, in another survey, and I'm sorry I just keep pulling these surveys, but they're really important. A vast majority, like I think it was like about something like 80% or more, thought that it was likely for a cocaine or alcohol dependent person to hurt others. So in addition to the violently mentally ill stigma stereotype, we can add drug user to that, and we effectively ratchet up further the stigma tsunami, this big stigma wave that individuals have to face. So over the last 30 years, a huge amount of research has described stigma, its consequences, and some of the intervention strategies. However, many people with mental health challenges and substance use disorders, we're members of multiple stigmatized social groups, and focusing on mental illness stigma or SUD stigma or any single stigma impacting the individual alone might not only fail to reflect their stigma experience, but it also likely will limit the effectiveness of any intervention. Health-related stigma, it's a complex phenomenon. And when you have that experience, it intersects with those of other adversities that arise out of social inequalities and oppressive identity things like gender, sexuality, and poverty. And this intersectionality between health-related stigma and other forms of social marginalization and manipulation can provide a fuller and more comprehensive picture of stigma that's associated with health conditions. For example, stigma across HIV/AIDS, mental illness, and physical disability can be co-occurring, might interact with other forms of stigma related to social identities like race, gender, and sexuality. And it is especially problematic for people living with these conditions because it can create barriers to accessing those necessary social and structural supports, which then intensifies their experience with stigma. And all this to say that as you engage with individuals who may be treatment averse, those individuals may be experiencing the effects of intersectionality, and those multiple stigmas may be occurring. And as with most health-related efforts, understanding the social determinants of health, how they impact an individual, that might help provide a glimpse or a clue, a bit of a signal that there may be multiple stigmas at work. And that makes the challenge of reducing them and eliminating them that much more difficult. Now, there's been this other content analysis. This one was in 2004. This one focused on media coverage. And I'm not going to read all the stuff on the slide, but what I want to point out to you guys, in 39% of these stories, an association was made between persons with mental illness and dangerousness. Treatment was mentioned in 26% of the stories, but only 16% of these stories included recovery as an outcome. So the media does not do us any favors when it comes to reducing stigma, and that should be something that you take away from this training. This is not bashing the media, it's just saying that they haven't represented stigma and stigmatizing impacts very well. We need to change that. Now, I've said all these things before. I just want you to know, the only thing I'm going to say about this for this slide, there was a great study that Johns Hopkins did, and only 22% of people surveyed were willing to work closely with somebody suffering from a drug addiction. That's 2 people out of 10. 62%, or 6 in 10, were willing to work closely with somebody who had a mental illness. Now, you can see we made this teeny bit of progress, but Lord have mercy, we have a long way to go. 2 in 10, we have a long way to go. So why do we even use stigma? What does it bring to the proverbial table? Well, we use it to maintain distance. We allow ourselves to be, away from them because they're not like us. It allows us to hurt others. It's a way for us to brand somebody as unworthy. You don't get love, patience, you don't get opportunities, you don't get treatment. It allows us to express disapproval. We can tell people, we don't like that, go away. It allows us to feel superior. I'm better than them. At least I'm not a junkie. It allows people to feel safe. That doesn't happen to me. Nope, and if we keep those people away, it won't happen to anybody we know either. And it allows us to promote some agendas. We see this a lot in, sort of in the political world. It allows us to control others. And so it's that control is a really nice thing if you want to keep people away from you. And finally, it allows us to express fear. And you've seen that over and over in my conversation today. It allows us to express fear about belief and behaviors of others that aren't like ours. There's plenty of challenges around how stigma is used. And what you're seeing here, I'm sure if you just spend a few minutes thinking about it, you'd come up with several additional ones on your own. So we know stigma is a huge issue in addiction. It's the #1 reason people don't come in for treatment. And it's also why they leave treatment early. We also know from studies across the world that drug addiction is the single most stigmatized condition on earth, more than having HIV or being a criminal or having a mental illness. And I've said this before, that's what I said. A lot of this stuff, it will feel a little repetitive, but I need it to be because it's important that we understand how challenging smashing stigma actually is. And it's also associated with poor health, barriers to treatment and engagement, and it's also, as I said, why we need treatment early. Now, we've got this idea of what stigma is. We need to talk a little bit about how we can reduce and potentially eliminate it. And I'm going to tell you now, it's not going to be easy. It's not going to happen overnight, but I think all of you know that. So having said that, let's just look at some of these strategies here. And as we do this, I just want everybody to step back for a second and just ask yourself, what if we treated chronic diseases the same way we treat folks who have a mental illness or an addiction? Right? What if we did that? Well, what if, we went to the hospital with chest pain and we were found to be having a big old heart attack, and the doctor and nurse told you it was your fault because you ate nothing but, Kentucky Fried Chicken and smoked, or that you didn't exercise. And what if they refused to give you any treatment because you did this to yourself with all them Kentucky Fried Chicken buckets? Or they gave you a list of cardiologists to call and sent you on your way. Good luck. What if instead of being given life-saving medication, you were told you could only get the medication if you agreed to go to nutrition counseling? Or what if you were kicked out because you were having a symptom of your heart attack disease? Now, this all sounds outrageous when you apply it to something like heart disease, and yet this is what people with addictions and mental illness face every single day. They're blamed for their disease, they're denied treatment, they're told to find care themselves, they're denied life-saving medications like methadone, Suboxone, and naltrexone, and they're kicked out of care for having a symptom of their disease. Return to use, relapse, however you want to call it, it still will get you booted. So it's not just the care and the treatment that's different. Even the language we use is different for mental illness and addiction when we compare it to other diseases. If you think about the language we use for most illness, it's a language that communicates compassion and a sort of a person-centeredness, right? We talk about cancer survivors and they're suffering or enduring this chronic disease. But the language we use for mental illness and addiction, both diseases, really different. We call patients substance abusers. We talk about dirty urine. And, we wouldn't call somebody with diabetes a sugar abuser. And we're definitely not going to call someone who is overweight a food abuser. But won't even think twice about doing that to somebody who has an addiction or a mental illness. And we use these similar disparaging and offensive language for those suffering with mental health challenges, just like we do for addiction. Psycho, crazy, drooler, rides the short bus. All these derogatory terms reinforce self-stigma. I've heard every one of them. I've probably used some of them in my past because all of us have done stigmatizing and we've all been stigmatized. All these reinforce that self-stigma, and it leads us to keep our challenges and our diagnoses secret, because if you don't know my history, you can't shame and stigmatize me for it. That's why we don't come for treatment. Now, I've got a few person-first language examples here. You're going to end up with them in the handouts that I can send your way. You can Google person-first language, strengths-based language, and you'll have everything I have. But the reason I wanted you to see this one in particular, because it separates the terminology examples into person-centered, neutral and objective, and then an opportunity-focused language. And I just really like how they've done this, because folks, words matter, and they matter a lot. So we've got to encourage the use of person-first language that really helps promote self-esteem and self-efficacy, like person with a substance use disorder instead of addict or alcoholic. Healthcare teams that use empowering language are able to diminish the why try effect of self-stigma, and it encourages engagement in peer support and education that helps you increase your social and your coping skills. Without that kind of education, I would definitely not be in this role I'm in today. And before we move on from this slide, it's important to realize that for many of us with mental illness or a substance use disorder, we often use stigmatizing language to describe ourselves. And we do it all the time, and in the process, we continue to reinforce our own self-stigma. I remember a long time ago when there was a counselor trying to convince me I was dealing with a mental illness, and this is why I was self-medicating. And I responded to her by saying, look, lady, I might be a dope fiend, but I ain't crazy. And basically, everything in that short statement is just dripping with internalized stigma, but that's exactly how I saw myself at the time. So how do we change the language to improve the care? Well, we'll just look at a few of the brief examples of what to say and what not to say. And honestly, you're going to be able to do a lot more of this on your own. But for now, we just want to focus on changing the language that you and we are using. Remember that stigma is the #1 reason that people don't come in for treatment. So if we want to improve the care, we've got to change the language we're using, right? So you're going to want to avoid these terms that are, like dirty and clean and, abuse and abuser. Just use person-first language. All that goes away. We need to move away from the idea of using the term MAT, medication-assisted treatment. Even though it's the #1 evidence-based treatment we have for opioid use disorder, it is highly stigmatized. Excuse me. And changing the language around it helps to remove some of that stigma. The term relapse or taper or detox, so relapse for me is a return to use. I don't use the term relapse at all anymore. And I never talk about a detox or a taper, because it's really, unless you said to the addiction clinic or your doctor, to hell with you, I'm done, and you leave the program on your own, it is a medically supervised withdrawal. That's medical language. And this is a disease. That's what it is, a medically supervised withdrawal. Now, remember when we first began this presentation, we talked about institutional or structural stigma. And if you'll remember, that's the type of stigma that has the discrimination in the healthcare system, which is often seen in the implementation of policies and language. And that leads to a lower quality of care, fragmented access, an overuse of coercion to get people to do what you want. 90 meetings in 90 days before we can talk about getting you housing. And I've done that myself to people I've worked with who are experiencing homelessness. As you may be realizing at this point, eliminating stigma, it's going to require work. And one of the ways to start, we just perform a language audit. We're going to review existing materials in our organization for language that might be stigmatizing, and then we're going to replace it. We can use the search and replace function for an electronic document, search for schizophrenic or abuse or abuser, and then replace that with the actual term. And if it is abuse, replace it with use or misuse. And then you got to review your internal documents and, really importantly, your external documents, because those are the ones your patients and your clients and folks who might be interested in treatment are going to see. And if there is stigmatizing language, they'll never show up. You won't ever know why. You'll just do exactly what we've been doing, saying, wow, nobody shows up for treatment. I don't understand why. We do now. We are mentioning these 3 stigma reduction interventions because we know, and I know they work, and there's evidence behind it to support them. So you can reach out to the CARE TA Center if you're interested in more of these, certainly around the intensive training pieces. Recovery community messaging teaches us how to more impactfully tell our stories, and the training also discusses the use of accurate and non-stigmatizing language. The science of addiction and recovery, hugely important because it gives you a background, a lay person's background in the neurobiology of addiction, and that matters. It matters a lot because it allows people to understand that this is a disease, it's not a moral failing. And while these trainings are all really great, and they definitely work, they absolutely work. Having someone with lived experience to provide education, we know has twice the impact on attitude change and intended behaviors that trainings without that voice experience. Twice. If you're a provider, you can reduce stigma around substance misuse by those language audits, by using person-first language. You want to challenge providers and the communities you're in to be aware of unintentional and implicit bias. And then you want to use the appropriate language in conversations whenever you're discussing mental or substance use disorders. So what can you all do? First, you do just what you did today. You learn more about mental illness, about addiction, you come to conferences like this, and you speak out. For everybody who knows somebody with an addiction, you can keep their hope alive and help them know that addiction is treatable and that they're going to get better. And I hope everybody's just mindful of the language they use, and remember, treat people with dignity and respect. Treat them the way you want to be treated, right? Please spread this message that treatment works and most people do get better in their recovery journey. We want to treat mental illness and addiction with science-based strategies, and we speak out against stigma, and we keep hope alive, and we treat affected individuals with dignity, and we partner with recovery coaches and peer specialists, and by God, we be mindful of language, and we will reduce stigma. And I'm only sharing this inventory of anti-stigma strategies because of how it breaks down each type of stigma, and it identifies the strategies to eliminate it and identifies the key audiences for those strategies. It's not something we're going to deep dive into here, but it's a really valuable resource to understand the players and the impact of each type of stigma. Now, this is the end of my session. I typically would have shown this slide at the beginning of this presentation so everybody in the room knew that I had the lived experience that validates why I'm in front of you today. But the reason I kept this until the very end is because I know the pervasive impact of stigma personally, both in the context of the mental health and addiction challenges that I have and as a speaker and presenter. And I've said repeatedly during this presentation that stigma may also keep people from seeking treatment. I was one of those people, and I'll tell you why. In 1996, I was court-ordered into a 12-step program, Narcotics Anonymous, knew pretty much everybody in there. It was a small community. I had been running the wheels off of black tar heroin right there, Quincy, California, Oroville, Marysville, and Sac. Those were my old stomping grounds. And you can see from the images that I ran it till the wheels came off. And in that session, I made the comment that I couldn't control this black tar heroin habit I had. And, you know, this methadone stuff seems to be something I'm interested in. You would think that I had committed the crime of the century. And I don't have to tell all of you how that might have gone in 1996, but suffice it to say, I left that meeting ashamed and swearing off that I would never use anything like methadone. And I kept that mentality for 3 years. I overdosed 3 times in those 3 years. And the final overdose, my partner said, you either go for treatment or I'm leaving. I went for treatment. And that was 20 years ago. I stand in front of all of you today. I wear my past and my recovery on my sleeves, because if you had met me in 1998, you just would have stepped over me laying in the gutter and you would not have given me another thought. And I'm in front of all of you today. I am telling you recovery is real. Co-occurring treatment, support, medication-assisted treatment works. And with the right support, those of us with mental health and substance use disorders, we don't only just recover, we go on to do great things in and for our communities, our brothers and sisters out there still struggling with behavioral health challenges, and for the families that they thought lost us forever. And David, you're right, it used to be called rehab. Those of us serious about our recovery also recognize when they might be headed for trouble. None of us is immune. And after 6 years of struggle to control not addiction symptoms, but mental health symptoms, I recently returned to MAT, to medications for opioid use disorder, medication-assisted treatment. And for the first time in my life, I also obtained some medications to assist in stabilizing my mental health. Remember when I shared that experience about the language where I told the counselor I might be a dope fiend, but I'm not crazy? I want you to imagine the level of stigma that I had to overcome to even ask about my mental health, let alone consider submitting to any testing to confirm it. Imagine too the level of stigma to overcome when, after we'd had a good solid diagnosis, they recommended medications to me. Good Lord. Fortunately, I don't listen anymore to stigmatizing messages. I've heard them all enough. I let the docs guide my feet because I haven't been too good at it over the past 40 years. And I decided to give my medications for mental health a shot as well. Let me just tell you, within 48 hours of Suboxone induction for my OUD and my PTSD and my anxiety, and my daily dose of Lamictal for my bipolar disorder, and Vyvanse for my ADHD, my entire life returned to a stable normal. And it has been consistently positive ever since. My resumption to MAT and the initiation of these very targeted mental health meds ensures that I'm going to remain in a loving relationship. I get to continue enjoying this fantastic job I have. I get to continue sharing to and learning from folks like you every day. And to say I'm blessed is an understatement, but no more so than anybody else in this room. So folks, I'm grateful to the CARES team for the opportunity to share all this with you. I'm grateful for you coming here and just listening to me today. I hope you found something worthwhile through this presentation. And I hope you all enjoy a fantastic close for this amazing conference. And we've got about 7 minutes. I'm happy to try and respond to some questions. I'm sorry I went a little bit long, but I thought that was really important. So thank you guys, very grateful. Sophie, what do you think? Do we have any questions?
I haven't seen any in the chat so far. Just a lot of interacting with what you've been saying. We just got one new message. Will there be handouts come tomorrow?
I will get them, David. I will get them out to you. I have your email from yesterday's session as well. And I'm with you. I will get them out to you. I've got some really good handouts. So I appreciate you just with the gentle nudge too. And you're right, a gratitude list does help indeed. I've really taken to that recently. So yeah, you're welcome. And if there's no questions, then I'm not going to hold people here for an extra 3 or 4 minutes. We can.
But we do have the survey. If you can fill that out, our event host can. If you can put that in the chat box, please. Please take the survey and let us know how we did. We appreciate you all being here, taking some time out of your day to listen. And once that's in there, I'm still waiting for send a message to her. Sorry.
No worries. All right. Wow, now I get to see all the people who were in this room, and there are people that were here from yesterday. So hi, thank you. We're able to see all you folks. It's wonderful. And did we get the survey into the chat, Sophia? Do you know? No, I don't see it.
The survey's not in there yet. I just sent a message to Kamal.
Fabulous. Okay.
Yeah. So once set up, please take the survey and let us know how we did. I have no more words.
Oh, and she's telling us, yeah, she's delayed. So let's see if she's got a little bit of a holdup. Bear with us 1 second, and we'll see if we can get that darn survey link in here.
I asked the other person. That's what it was. Okay. Also, I hope y'all are enjoying the conference. I've heard some great things about the other sessions and panels. I attended one, I facilitated another panel that had to do with talking about cultural competency, which was really great. And I don't know if any of you attended it, but the energy and the love in that room was just tangible. And if any of you want to share in the chat box while we wait to get that set up, some of the sessions that you're excited to go to next, please let us know.
Wonderful, Sophie.
And Stephen, do you have any other sessions after this?
I am going to moderate 2 this afternoon. And so I presented in 2 sessions over the course of this conference. And so David, I'm now in Nashville. I live in Nashville, Tennessee. And I've been here for about almost 20 years now. But I'm trying to return home. Home for me is really the sort of Tahoe, Reno, Tahoe area. You know, I miss the mountains terribly. I miss the weather. I miss people. I miss a lot about home. And home for me is Cali and sort of northeastern California. But yeah, I miss it a lot. I have a lot of kids there too. There is our lovely survey link. Kamal, thank you so much for finding that and getting it in the chat. And folks, please take a minute, fill that out, tell us the good, bad, and ugly. We really listen, and we use that to improve who we are and what we do. And again, thank you all for your time today.
All right. So once you get that survey, you're free to go and enjoy the rest of the conference.
Awesome. Sophia, thank you for your moderation for the last 2 days. It's been fantastic.
Oh, thank you.
You're welcome. Have a great day, folks.
Bye, everyone.